with an introduction, just generally go over the pathophysiology and the classification of cardiorenal syndrome, some of our later and more recent understanding around some of these pathophysiological mechanisms and some of the caveats to the existing classification. But I want to spend a fair amount of time particularly talking about type 1 cardiorenal syndrome, which is very relevant to your practice, and focus on some of the lack of clarity in both making the diagnosis and some of our management dilemmas with worsening kidney function in patients with heart failure, particularly with respect to decongestion. And again, because this is a talk for intensivists, I want to focus on the smaller subset of patients with heart failure that present with cardiogenic shock and talk a little bit about kidney function and acute mechanical circulatory support devices and whatever we know in this space. And, honestly, there are more questions than answers, but I think it's just fascinating when you look at these device-patient interfaces and impact on kidney function. And then we'll talk about some conclusions and future directions. So, the literature is very rich in the cardiorenal syndrome space with notations of this close heart-kidney crosstalk from as early as in the 1800s. So this is a manuscript by Sir Richard Bright, who is widely regarded as the father of modern nephrology. And he describes an autopsy series of 52 patients where he shows the structural changes in the heart noted in patients who had died, who had shrunk kidneys and were noted to be secretors of albuminous urine. So that's your typical prototype proteinuric CKD patient as we know today. And a lot of those structural changes are what we call CKD-associated cardiomyopathy. And since then, all the way through the early 1900s up until now, our understanding of this heart-kidney crosstalk has been advanced through a lot of seminal work in understanding interactions from, the right side in terms of venous congestion, as well as on the left with forward flow. And while a lot of the teaching has tended to focus on the low flow state and the effects on kidney function thereafter, the data for the renal venous congestion, which is almost a prerequisite and a requirement for the development of cardiorenal syndrome, some of that literature is from the early 1900s. But it was around 2010, where led by Claudio Ronco and others, that there was this first attempt at trying to come up with a clinical classification of the different phenotypes of cardiorenal syndrome based on two concepts. One was whether it was acute or chronic, and two, what the leading organ is for dysfunction, whether it is the failing heart or the failing kidneys or the primal movements. So based on that, cardiorenal syndrome, as you all are probably familiar with, this is one of the commoner classifications used, is classified as cardiorenal or renal cardiac, and then further into acute versus chronic. A lot of what I intend focusing on today is type 1 cardiorenal syndrome, which is renal dysfunction in the setting of acute heart failure. What is equally important to appreciate that is that when you talk of this bidirectional crosstalk, especially in the hospitalized patient, we tend to get very obsessed with the hemodynamic part of the crosstalk. Changes in filling pressures and thereby the effect on kidney function, for example. However, it's really important to appreciate that in a patient with decompensated heart failure, the other axes where you see this bidirectional crosstalk, namely the neurohormonal pathways, notably the renin-angiotensin-aldosterone system and the sympathetic nervous system, as well as the inflammation axis, are equally important. And unless a patient is optimized across all these different interfaces, you're truly not addressing the core problem with the compensated heart failure, and therefore all the secondary outcomes, including kidney dysfunction, will follow suit in terms of being unoptimized. This is from a recent review that we published in NEJM Evidence, and the purpose of this figure is to show that acute heart failure is actually a multi-system disease. It's not even just these two organs and the crosstalk pathways that we were talking about. And importantly, we now, as we've already seen and described, right-sided congestion and renal venous pressure elevation is a sine qua non for the development of cardiorenal syndrome. In a small subset of patients, the dominant mechanism is poor forward flow. And we're going to talk about some of the differences in identification and in the management of these patients. But we're also beginning to appreciate other important aspects. And especially in critically ill patients, elevated intra-abdominal pressure is one such aspect, wherein which you see abrupt onset of oliguria in these patients with decompensated heart failure, which is relieved when you reduce intra-abdominal pressures. The emerging role of the gut as well as the microbiome of the gut contributing particularly to that inflammatory component of heart failure is also beginning to be appreciated as an important mediator. We're also paying more attention to the role of the liver, both as a mediator as well as a bystander in the process of congestion. And within the kidneys themselves, because of that renal venous hypertension and the resultant increase that you see in the interstitial pressure, we're now beginning to appreciate more the role of the kidney lymphatics. In fact, because in order to compensate for that increase in interstitial pressure, the lymphatic washout to compensate in patients with heart failure can increase, and the flows that you see in the lymph channels can even approximate ureteral flows for urine. The resultant decrease in interstitial oncotic pressure further facilitates a sodium avid state. Another aspect that we're beginning to appreciate more is the role of the kidney's capsule itself, because as you can imagine, as you have increased interstitial pressure and you have kidney swelling and you have this very tight fibrous capsule kind of exerting a pressure, in the opposite direction, that in itself can contribute to significant reductions in renal perfusion pressure. So in a way, it's also not very dissimilar in the way in which you think about cerebral perfusion pressure. And, we, rather than just use, terms like mean arterial pressure and CVP, and by extrapolation, renal venous pressures, you're more interested in the driving force, which is the difference between the CVP as well as the mean arterial pressure as what ultimately determines renal perfusion pressure. So now, with that brief overview on some of the key pathophysiologic mechanisms, let's take a look at type 1 cardiorenal syndrome in particular, and talk a little bit about the interpretation of fluctuation in kidney function and whether a rise in creatinine in these patients is always a bad thing, particularly in those in need to be decongested. This is a common problem in hospitalized patients, and this conundrum of, yes, this patient clearly needs to be decongested, but their serum creatinine continues to rise, and what do we do? A common and reflexive tendency is to assume that that rise in creatinine equals acute kidney injury and therefore cannot be a good thing for the patient, because as you all know better than anyone else, any degree of kidney injury, even subtle kidney injury, is a determinant of poor outcomes, especially in critically ill patients. And that is why kidney function always is prominently featured into every prognosticator and scoring system that you have for critically ill patients. However, in the context of heart failure, are all rises in creatinine a bad thing? So let's take a deeper look at that. So this is a seminal paper from the Yale Heart Failure Group that was published in 2018. And they looked at worsening kidney function in patients with acute heart failure undergoing aggressive diuresis and changes in markers of kidney function. So the platform that they used here was the ROSE heart failure trial. And these patients were patients who were hospitalized with acute heart failure, and they had complete data on 283 patients. The study premise was very simple: to determine if renal tubular injury, or ATN, as we know, which is a dominant cause of kidney injury, especially in these kind of hospitalized and critically ill patients, was a predominant cause of worsening kidney function in those undergoing aggressive diuresis with acute heart failure. So how did they look at this question? They looked at changes in markers of glomerular filtration, that is, changes in serum cystatin C and serum creatinine. And simultaneously, they also looked at biomarkers of tubular injury. And you may be familiar with some of these, KIM-1, NAG, and NGAL. Some hospitals, and I'm not familiar with your hospital's protocols, can actually incorporate this into their clinical practice for early detection of acute kidney injury. And these are well-validated biomarkers of tubular injury in patients with actual ATN. And these tubular biomarkers were measured at 24, 48, and 72 hours. And what did they find? So what they found was, when you look at those that did or did not develop worsening kidney function, a fifth of patients in this cohort developed and met the criteria for quote unquote AKI as we know it by, like KDIGO criteria, or by using other criteria like Aiken or Rifle. But interestingly, when you look at the patients and you look at their urine tubular biomarkers, there are no significant differences noted in those that did or did not develop worsening renal function or quote unquote AKI. What was even more interesting was when you looked at 6-month survival in these patients who were hospitalized with acute heart failure, patients who left the hospital with the highest level of serum creatinines, the ones that we would get worried about from a kidney perspective, actually had the best survival. Patients who left the hospital with lower creatinines or cystatin C levels actually had the worst survival. So this is an example of where there is this antithetical message, where, oh, AKI is a bad thing. It is a bad thing if the patient is truly experiencing tubular injury. But the point here that is being made is in patients with acute heart failure, wherein changes in markers of glomerular filtration, such as cystatin C and creatinine, are largely mediated by hemodynamic changes in the setting of aggressive decongestion, as well as neurohormonal modulation with using agents like ROS inhibition, using angiotensin neprilysin inhibition, MRAs, etc., may not carry that same negative predictive value. And it's very important to make that distinction, because while these benign changes in creatinine and cystatin don't necessarily portray a negative outcome, the persistence of congestion and unoptimized heart failure does carry a mortality signal, and that is an important distinction to make. So more along these lines, this is a post-hoc analysis from the well-known ESCAPE trial. And in ESCAPE, what they're doing here is congestion in patients with acute heart failure was measured in different methods, using right heart cath data, using clinical criteria, using markers of hemoconcentration, and estimates of plasma volume. And when you look at death at 6 months, in patients who developed worsening kidney function and were persistently congested, regardless of how you measured and quantified congestion, that combination of patients had the highest hazards for death. However, if patients develop worsening kidney function but were euvolemic, that is, they were completely decongested appropriately and experienced that rise in serum creatinine or cystatin, that worsening renal function, quote unquote, lost the same negative predictive value that you would ascribe to a patient with true tubular injury. And this is a more recent analysis from colleagues in nephrology at Tufts, led by Wendy McCollum. And this is an analysis from the Everest heart failure trial, where they looked at tolvaptan in patients with heart failure. And what they did here was to look at the hazard ratios for death associated with a decline in eGFR when interpreted as a standalone entity versus within the context of decongestion. And as expected, when you look at decline in EGFR as a single entity, any decline in EGFR is associated with an increased risk of bad things in general. In this, they were specifically looking at mortality. However, when you interpret that decline in EGFR in the context of decongestion as measured by declines in BNP, or an increase in hematocrit as a marker for hemoconcentration, then you did not see that negative association. So the point that I want to make by presenting these data are that it is really important to be able to tease out, and this is not a subtlety, it's not a nuance, it's almost one of the most important early decisions you will make, which is separating patients into those that appear to have AKI based on our predefined criteria, but truly don't have tubular injury versus those that do, like your patients that are septic on 3 pressors with septic shock and other actual intrinsic, renal insult that is going on. And the problem with applying those criteria to patients with acute heart failure is 2 things happen. One is it is assumed those patients have a worse prognosis, which is partially true if the disease is untreated. But importantly, even if that represents a sicker group of patients, they do respond to therapies, and importantly, decongestion and neurohormonal optimization. And worsening kidney function can be the biggest barrier in the path of those patients to optimization, and thereby their outcomes are poor. And therefore, it then becomes a chicken or egg situation as to, is it the disease or is it failure to treat the disease appropriately? So this is still one of the biggest, Achilles heel in my mind in the cardiorenal syndrome space, where there is an urgent and unmet need in terms of solidifying appropriate terminology to describe changes in kidney function, particularly in those with decompensated heart failure, such that our very own definition doesn't imply we are causing harm, and thereby depriving patients of being able to be appropriately decongested and on appropriate GDMT for heart failure, of which we have now made so much progress in terms of being able to really, really improve survival as well as quality of life. Interestingly, renal function, again and again, is the biggest rate limiting step in achieving those important outcomes. So what outcomes from a kidney perspective, if not changes in creatinine, should we actually then care about? I'm just trying to kind of pull you away from getting, hung up on, these changes in creatinine. So what actually should we be looking at? We should be interested particularly in patients that are diuretic resistant. That phenotype of patient is going to do poorly. Their mortality, including in-hospital mortality, is exceedingly high as compared to those that are diuretic sensitive. And generally implementing GDMT in those patients is going to be challenging. So what is a quick way in terms of clinical practice to quickly separate out and identify that sicker patient with cardiorenal syndrome that is diuretic resistant? This is a protocol that was devised by Wilfred Mullins, a leading heart failure expert, and his group in Belgium. And this is a great strategy where patients who are admitted to the hospital with evidence of congestion, volume overload, when you initiate loop diuretic therapy, the strategy to separate out these diuretic resistant patients is to be able to diagnose sodium avidity early on. So the expectation is when you have them on what you think are pharmacologically appropriate doses of therapies in terms of loop diuretics, when the drug is at its peak level, which is typically around the 2-hour mark after the injection of a loop diuretic intravenously, that you should be losing a fair amount of sodium, because ultimately the goal of decongestion is natriuresis. So a simple way to quantify that is to check a spot urine sodium. This is readily available in any hospital. The turnaround time shouldn't be more than 30 minutes if you send it stat, and it gives you an immediate answer. If 2x dose of the loop diuretic, you find that you're able to generate a urine spot sodium at 2 hours, somewhere in the ballpark of 50 to 70 milliequivalents per liter, that represents what would be considered an appropriate natriuretic response. If you've given them what you think is a pharmacologically appropriate dose, and then go in and check a urine sodium at 2 hours and the urine sodium is less than 10, you actually did nothing to the disease. Nothing actually ever happened. It doesn't matter what the patient's urine output was or not, because they are still extremely sodium avid. And that is an immediate nudge that that dose needs to be doubled. It needs to be quickly escalated. And if after a couple of rounds of doing that, other strategies, including the use of techniques such as dual, diuretic use, multi-segment nephron blockade, etc., need to be invoked, so that you don't end up with a patient that is struggling after their 4th or 5th day of hospitalization and doing poorly. Of all the classes of diuretics that we use, obviously in real world practice and in patients with acute heart failure, loop diuretics are the most commonly, the first line agent when we think of decongestion. With the advent and all the great data that we have with the SGLT2 inhibitors, I think it is appropriate here, even to a critical care audience, to mention some of the differences between how these may work as diuretics versus loop diuretics. Some of the cardinal differences are the impact that different classes of diuretics have on neurohormonal markers. And I keep coming back to this concept because in heart failure, which is primarily, the aberrant pathways are initially neurohormonal in nature, and then the secondary pathways involved are the hemodynamic perturbations. So ultimately, the goal is to optimize from a neurohormonal perspective. On that note, loop diuretics, while they are our go-to agents for decongestion, they actually make the maladaptive ROS and sympathetic nervous system state worse in patients with heart failure. This is a nice study from Jeffrey Testani's group where they actually measure several of these biomarkers, neurohormonal, renal biomarkers, cardiac, inflammatory markers, erythropoietin generation in empagliflozin versus placebo in patients with acute heart failure. And what is really interesting to see here is that where you would actually expect, renin levels to go up, you would expect aldosterone levels to be high and norepinephrine levels to be driven up, as with the use of loop diuretics. Here you see pretty much a null effect. And that is really, a very smart way of being able to achieve both decongestion as well as not make the neurohormonal state of heart failure worse, which has generated a lot of interest in the use of SGLT2 inhibitors, potentially not just as adjunct diuretics to improve diuretic efficiency, which has been shown in some single center, smaller scale studies. This is a recent trial that came out in The Lancet, led by Adrian Boers, called the MPulse trial, where they looked at empagliflozin versus placebo in patients that were hospitalized with heart failure across the ejection fraction. And here they used a primary composite outcome, and the different elements of these are described here: time to death, heart failure exacerbation, time to heart failure exacerbation, KCCQ, cardiomyopathy scores, and they used a technique called a win ratio to assess clinical benefit. And the patients that received EMPA versus placebo experienced a 36% higher likelihood of experiencing the benefit of this primary composite outcome. So I think you will see more of this even in the critical care space. And, as an intensivist, I think one of the questions that may come to you is, all the SGLT2 inhibitor data, both from a heart failure perspective and kidney perspective, sound wonderful in the outpatient setting or even in less sick patients. But is there really a role in critically ill patients for these agents that just seem to, have this golden touch with everything? The answer is, at this point, I don't think we quite know. But at least, the closest attempt that has been made so far is with a trial that came out, I believe, in 21, the DARE trial, which looked at dapagliflozin in patients hospitalized with COVID-19 pneumonia that were at least at the level of a moderate level of illness. The study itself did not meet its primary endpoint, but it did show that the SGLT2 inhibitors could be safely used even in sicker patients who were hospitalized. I think it would be really interesting, and particularly interesting in those with acute heart failure, including patients who may be critically ill, eventually, if there may be some benefit to maintaining patients on SGLT2 inhibitors if they were on them in the first place, or the de novo initiation. But at this time, there aren't any data to report in that critically ill patient space. One of the questions that comes up that is relevant to you is, at what point does decongestion now mandate a switch from pharmacological therapies to mechanical decongestion? And in the last decade, this space, the ultrafiltration in heart failure space, has seen a complete turnaround from where it was, say, around in the early 2000s to the late 2000s. A lot of the interest in ultrafiltration for heart failure came about for two reasons. One is if patients were truly diuretic resistant or kind of headed in that way. And second, the understanding, at least from preclinical models that I just showed you, that typically when you use escalating doses of loop diuretics, you actually rev up the RAS and the sympathetic nervous system, while with ultrafiltration, it has a more neutral effect, and that was therefore theoretically assumed to be beneficial in the overall outcomes with patients with heart failure. And one of the earlier studies in that space, called UNLOAD, that looked at early ultrafiltration versus pharmacologic decongestion with loop diuretics, they found some benefits with some secondary outcomes. The trial did not meet its primary endpoint. And that set forth, the notion that maybe there is a role for mechanical decongestion, and perhaps even early in the course of heart failure. So this was a study actually led by Jean Braunwald called the CARESS heart failure, which tested that question in a much larger randomized controlled trial, where they looked at ultrafiltration in patients with type 1 cardiorenal syndrome versus a stepped up pharmacological loop diuretic based decongestion strategy. And when they looked at the primary outcome, which was a bivariate of changes in creatinine and change in weight, there was no difference between the two arms. And in fact, a higher rate of adverse outcomes were reported in the patients undergoing ultrafiltration. Now, there's a lot of nuance to the interpretation of these findings, but it did answer one question well, which is, upfront in patients with type 1 cardiorenal syndrome, there is no role for early initiation of ultrafiltration. And even when you look at the protocols that were used in studies like CARESS heart failure, the doses of loop diuretics were absolutely humongous and not consistent with the type of doses we are typically used to seeing in real world practice. We've actually come further since CARESS was published in terms of our understanding of how to optimally, kind of pair diuretics. And there are even some prospective RCTs being conducted on these kind of diuretic, this kind of using or testing the concept of what is called multi-segment nephron blockade, wherein you can potentially achieve higher rates of diuretic efficiency by using an inhibitor of the PCT, of the loop of Henle, using a distal diuretic and/or an MRA. So there are some good single-center data that support that thought process, wherein rather than just use higher and higher doses of loop diuretics, there may be benefit to using a more even strategy by diuretic combination therapy. And we hopefully will see some high-quality data in that space in the future. But as far as where do we pull the trigger for ultrafiltration at this time based off the data from CARESS? It is typically in patients that truly are declaring themselves to be diuretic resistant to standard pharmacological therapies, including with multi-segment nephron blockade. As intensivists, I think you will really appreciate the importance of this figure. And, even if a patient is not in your ICU for a primary cardiac reason, the overall fluid balance is a big determinant of their outcome, both within that ICU stay, the ability to safely be discharged from a hospital, and even outcomes such as 30-day mortality. And both extremes, extreme underfilling as well as overload, are deleterious, and there are quite good data in the critical care space that cumulative fluid burden is a predictor of poor outcomes. And presumably this is, because even if a patient isn't primarily there with decompensated heart failure, that overall can recreate that CRS physiology and that renal venous congestion and that multi-system involvement with all those other aberrant pathways, eventually, if that state is persistent and not addressed early on. This is a single center study that we did where we looked at the association of a restricted fluid approach versus a more liberal IV fluid resuscitation approach, less than or greater than 30 mils per kg in patients who are post-cardiac arrest. And here in this panel C, you see the distribution of the different etiologies of cardiac arrest. And while a liberal versus a restrictive strategy per se did not determine or was not shown to be associated with any major differences in the outcome for 30-day mortality after the ICU stay, in patients who experienced the liberal fluid strategy, there was an association with higher vasopressor use and more prolonged mechanical ventilation. So it is certainly something that is of importance to consider, the whole physiology in terms of the CRS pathways that we talked about, even if they were not primarily admitted for that purpose. And, that was one question, the post-cardiac arrest state, where I think that nuance has not really been very well delineated. So that was an attempt to just see if that signal overall panned out, which I think it did. And I think, in that critical care space, or in patients who are kind of on their way to becoming critically ill, in the algorithm for the treatment of cardiorenal syndrome and where we look at decongestive strategies, this point tends to be a very important pivotal area where things can go well or things cannot go well. And that's a marker of patient sickness. When you start beginning to think, does this patient need a right heart cath? And by extension, one of the big reasons why that question may come up is because you are really worried about a low flow state. Now, it is one thing to do that in a patient that has already established themselves as being critically ill, but a lot of the times these patients are not directly under your care. They're on the floors, they're in much less monitored settings, and they are potentially in a pre-shock state. And it becomes extremely important to be able to identify that patient that is going to do poorly and escalate care. And a lot of the times when you look at this algorithm for, how to decongest and some of the points that I made here about diuretic resistance, it comes and hinges upon this important question. Is this one of those minority patients in the subset where they have a low flow state? Which then brings me back to the question, when is right heart catheterization actually appropriate in patients with type 1 cardiorenal syndrome? As we know from ESCAPE, there is no role for routine performance of a PA catheter-based strategy-guided therapy for patients with acute heart failure. However, in patients with cardiorenal syndrome, particularly those patients that are diuretic resistant, and you've tried these different pharmacological maneuvers, including multi-segment blockade, appropriate, ensuring natriuresis by appropriate dose escalation of loop diuretics, treatment of elevated intra-abdominal pressure, and other reversible factors, there are select indications, especially because that is now an enriched group of patients that may be at risk for a low flow state. So I think in those patients, a lot of the times we're surprised when we actually see that we've been sitting on a patient in cardiogenic shock, although they didn't look like they were in cardiogenic shock. Other indications would include the need to more accurately estimate PA pressures, particularly quantify PVR, and institute appropriate therapies. Sometimes if you're not sure about the degree of concomitant valvopathy, and sometimes in patients, and this is more relevant to patients with advanced heart failure, getting prognostic information from some of the novel hemodynamic indices for RV function, such as the pulmonary artery pulsatility index or the RV stroke work index. These are not go-to, variables to reach out for right away, but in that patient, particularly in those patients with diuretic resistance, if immediate and appropriate pharmacologic therapies don't quickly produce the intended results, I do firmly believe that right heart catheterization adds valuable information in that subset of patients. I want to spend a bit of time, because I think it's relevant to you all, to kind of think a little bit about the acute mechanical circulatory support devices and what little we do know about impact on kidney function. As you all are well familiar, there's been an exponential increase in the use of these device platforms. And the attractiveness of the percutaneous AMCS platforms is they can be quickly deployed in the critical care setting without the need for surgery and extensive procedures. Overall national trends, as shown by NIS data, reflect a slight decline in the use of balloon pumps with a corresponding increase in the use of ECMO, as well as for the percutaneous VADs, or, in the most common ones you see are the Impella family of pumps. And when you think about the, patient with cardiogenic shock, I really like this framework, and this is, something that has been kind of delineated and propagated by Naveen Kapoor, who's a well-known expert in cardiogenic shock, which is the hemodynamic support equation. So the goal with these platforms is to achieve 4 major objectives, as you can see here. The first is you want to perfuse your patient. The second is ventricular support. And this is where devices tend to differ in how well they are able to support the ventricle. And particularly, you're interested in LV and or RV unloading. The third is to ensure that coronary perfusion is maintained. And that's not just in the setting of an AMI with cardiogenic shock. It is in any patient with cardiogenic shock. And the fourth is when you look at the fact, and as I had alluded to before, this is a disease, acute heart failure, and cardiogenic shock in particular is a multi-system disease. And one of the immediate consequences is not just the underfilling, but the fact that there is rapid onset of congestion because there is no appropriate way in which you can simultaneously be in shock and also be able to effectively decongest. So in that case, worsening kidney function, worsening liver function, and a lot of the downstream effects and the vicious cycle with unoptimized cardiogenic shock is very well known to you. So supporting and, being able to offer a platform for early unloading is also one of the larger objectives. How well it's achieved is a whole different issue, but is one of the larger objectives. These are examples of metrics that actually can be targeted with these different platforms, and they all have different principles and ways in which they achieve this. And these are some of the end biomarkers that we commonly use. And you're probably familiar with these, but it's worth repeating here just to broadly how these platforms are classified. So these circulatory support devices are largely first grouped into either the pulsatile pump category, which is the balloon pump, or the continuous flow pumps, under which you further divide them into whether they're axial flow based or centrifugal. In this, the Impella pump of families, the percutaneous HeartMate is not available for clinical deployment in the United States. And here, probably the most common one that you see is VA ECMO. So when you have a patient on one of these AMCS platforms and you're asking the question about what are the downstream kidney effects, I think it's important to frame, the background of what you're dealing with in that patient. One, what is the clinical backdrop and the physiology of the shock, and how did they get there in the first place? What are the hemodynamic expectations with the insertion of a given device? And this is where a lot of detail is important in understanding which class of pumps you're talking about and what the effects will be on the pressure volume curve of the left ventricle. And thereby, when you understand that part, it is then easier to extrapolate what the downstream effect would be on kidney hemodynamics. Again, you're all familiar with this LV-PV curve, but again, especially for the fellows and other trainees, is back on that PV curve. So the primary hemodynamic objectives in the patient with cardiogenic shock are to provide circulatory support, LV and or RV unloading, which I talked about, increasing myocardial perfusion and reducing demand, and facilitating multi-organ congestion. I don't think I'm going to spend a lot of time going over the different concepts and the pumps because I think it won't leave us with adequate time for discussion, but this is a figure showing you the placement of an intra-aortic balloon pump. The current evidence for the use of a balloon pump, especially after the shock trial, failed to identify any mortality benefit with balloon pump use compared to medical therapy alone, particularly in patients with AMI. These were the only patients included in shock, and cardiogenic shock significantly led to much less use and deployment in that particular context. In patients with cardiogenic shock, the ESC, it actually gives IABPs a class 3 recommendation, saying that routine use of intra-aortic balloon pumps is no longer recommended in those patients. And it has a class 2A level evidence with the ACC-AHA guidelines. From a kidney perspective, there have been some earlier studies when the use of balloon pumps was more prevalent to see if there were downstream renal protective effects. And this is from a small case series of patients undergoing a CABG, where the renal blood flow was measured using Dopplers and by calculating something called a balloon index, which was the peak renal artery velocity divided by the mean velocity before the placement of a balloon pump and after during the course of the surgery. So in this small case series, there was some evidence that there was better renal perfusion, particularly in diastole during surgery. However, other smaller studies that have also measured renal perfusion in different methods have failed to show any major renal endpoint benefits. It is also fair to say at this point that across all those different family of devices for AMCS, no single one has panned out in terms of being any more nephroprotective than the other. So if there is any push to use a device theoretically for renal benefits, I want you to know that that is not based on any level of high quality data. This is
Dr.
another.
Rangasamy,
Yes.
you have given us such a fantastic overview that I think it may not be a bad idea to leave these 10 minutes for a Q&A session. And we're
Oh,
going to have
absolutely.
you back because really the reason I invited you was your remarkable review of cardiorenal interactions
Mhm.
in New England Journal. What a fantastic high-level review. And it just so happens that, we have a very robust cardiac critical care group right here, and we do all of these procedures and are probably the largest volume center for using ultrafiltration.
Oh, okay.
Yeah, in the country, apparently the most number of ultrafiltrations done are right here in Mount Sinai, and not only for the cardiorenal syndrome, but
Mhm.
also for other fluid overload states.
Mhm.
So, if you wouldn't mind, we
Absolutely. Yeah. Like I said, we want to keep this. This is
yeah,
almost the end of the talk, but
yeah.
let's get back to whichever areas that
Okay,
let me
so why
first.
don't would you like to, just wrap up your last few slides? I really
Yeah, well,
want
that
to
was just to show
engage.
some
Yeah,
more
yeah, yeah.
impella and renal function data. I
Perfect.
may want to, point out here
Yeah.
that you will see a lot of these, I'm sure you're a huge ECMO program. I'm sure you have a shock program. A lot of the renal, effects, like the main message I want to say when you're talking about the patient in cardiogenic shock and the use of these AMCS devices is no one device has been shown to be superior to the other, particularly in terms of renal outcomes. When you look at some of the adverse renal outcomes, obviously ATN is a dominant problem. Hemoglobin pigment nephropathy, given the high risk of hemolysis, especially with these high rotary pump devices. In patients with ECMO, you almost see like an AIN-like physiology where there's so much of inflammation in the kidneys, and these are shown in some nice animal models. So these are all some of the dominant pathways of injury. So, the main conclusion that I wanted to make is identifying patients, especially the type 1 cardiorenal syndrome, particularly the diuretic resistant phenotype, is very critical. And not getting hung up on the definitions of AKI and rising creatinines in the name of, pulling back on decongestion and appropriate implementation of GDMT is really important. If there is one take-home message, and that paper, that whole NEJM evidence review I think, made that point again and again, which is when we look at kidney function in patients with decompensated heart failure, we have to be really careful what the outcome of interest is. The outcome of interest truly is that type 1 patient, particularly the diuretic resistant patient. When you look at the low flow state, the use of acute mechanical support devices, we saw a little bit of the overview and some of the pump physiology. No one particular device is superior to the other. The rates of AKI of true intrinsic injury are really high. Early triage and the use of multidisciplinary cardiorenal teams is really important in identifying the sicker phenotype of patients to optimize outcomes. So, Dr. Gidwani, I'm going to stop here, and I welcome any thoughts you have and any points that you particularly want to discuss, especially because you expressed, you shared that you're a huge UF program. So I'm happy to, learn what your experience is and answer any questions.
Well, I really want to open up this now to the group so they can ask questions. So I encourage people to ask questions. You have in your presence really a master in cardiorenal syndrome. And it's really important because I find that a lot of the residents rotating through the cardiac ICU get a little worried when the renal function, or at least the markers, the standard markers of renal function, such as BUN and creatinine, worsen in the face of increasing diuretics. And there's been so much confusion. So I'm going to open this up for questions, and I encourage questions, please, for Dr. Rangasamy.
Dr. Gidwani. So my question is, I actually had a patient like this the last time I was in the CCU, where I had this patient who had just had a TAVR, had pretty bad TR, was very volume overloaded, hadn't been being diuresed adequately at home, came in decompensated with some respiratory distress and massively volume overloaded. And she was being aggressively diuresed with Lasix drip, metolazone, and wasn't really responding. So we made the decision to switch her to aquapheresis and start pulling. And we were able to get, over the course of a long weekend, like 5, 6, 7 liters of fluid off. She was still volume overloaded, but much improved. I guess my question to you is, after we stopped, we were like, her creatinine was going up. She wasn't making any urine, which was expected since we were pulling all the volume. But how do you transition off of the aquapheresis back to kind of trying to get her kidneys to work? And what are your thoughts on, is there any risk of permanent damage to the kidney by taking away all the blood flow and using the aquapheresis?
I think all those are excellent questions. You have to approach it with, the following questions. First, why was that patient diuretic resistant? Why did they fail pharmacologic therapy to the point they needed ultrafiltration in the first place? So in your case, it appears that, that the TR was probably playing a big role there. So ultimately, something that eventually will help reduce torrential TR is going to be the final treatment of that patient's cardiorenal syndrome and diuretic resistance, right? So in the acute setting, when you have this decompensated patient and whatever you're trying to do, their CVP is going to be, above 20. And bear in mind that you're not trying to normalize CVP in that patient with wide open TR. There is a role in that patient when you've tried this and that, and they're just decompensating on you, to pull the trigger for UF, which you did. The problem is, in that patient, again, if you haven't fixed the underlying problem, why would that patient now do well? Again, sometimes in these cases, you have to try to see, because in some cases, that modest reduction in right atrial pressures is good enough to convert a diuretic resistant patient to diuretic sensitive. And there is a strategy. You may have a window where you now have them on a combination of a loop and a distal plus minus, a proximal diuretic. There was a recent trial, the ADBOR trial by Wilfried Mullins, where they had the addition of acetazolamide along with loop diuretics and, showed, better ability to decongest. So some of those maneuvers, there may be a small window, and sometimes ultrafiltration buys you that window. But ultimately, this is just a patient's RV screaming for help. That's it. You can fix it or you don't. And if you don't fix it, that patient's not going to come off the need for mechanical ultrafiltration. And if they are, they're going to be left with a GFR of less than 20, teetering along. And every time they sneeze, their creatinine will go up and they'll eventually declare themselves as diuretic dependent. In these patients, my strategy is actually put them on PD, not to dialyze the patient, but to maintain volume in that patient without committing them to long-term thrice a week hemodialysis, where they're going to do really poorly, especially if that RV is not going to recover. So you're always looking at, and that RV dysfunction is the death sentence for a patient who's going to go on dialysis. They're just not going to do well. In this patient, if your patient didn't come off ultrafiltration, rather than try a little bit of this and a little bit of that, put in a PD catheter and send them home on PD, they will do great. You'll keep them out of the hospital. They won't keep coming back oliguric and fluid overloaded, and you're buying them time. And hopefully there is some resolution for why that patient has TR. Are there some strategies that can be used medically or surgically to fix that? That would be my approach.
What a great novel approach, putting PD for people like this. That's amazing.
So it's not novel, Dr. Gidwani. There is some experience with this. One of my colleagues, Amir Kazuri at the University of Florida, another cardiorenal expert, has a huge practice of heart failure patients on PD. And we really have to ask ourselves, PD is not to be viewed as a dialysis tool. It is a great intermediate tool for volume management.
Amazing.
In patients either with advanced heart failure who are not a candidate for a VAD, who would do poorly on dialysis, or with these RVs that are going nowhere. So one of those two combinations of patients, you can actually get them approved for outpatient PD, even if their GFR is not in the end stage kidney disease range. So the patient can have a GFR of 20 to 25 and can still be on PD, but that is more for decongestion and for quality of life and keeping them out of the hospital.
Amazing, amazing. It's really interesting because in England at Cambridge, there is a cardiorenal team, and the nephrologist does, you know what I'm talking about, right? And they're doing this phenomenal work. But I don't see that happen a lot in the US, especially in advanced cardiac centers. But this would be a great tool, as you said, to manage volume rather than large molecules. Now,
correct.
Yeah, I would like to reiterate the point that you made, which is that don't be afraid to use diuretics or decongestion. All you have to do is to determine if the patient is congested or not, and then let the chips fall where they may. Now, Mullins's approach, right? So I had a chance to ask Mullins this, because in Europe, they use the urine sodium-based strategy to escalate diuretics. Yes. While in the US, they use the urinary output-based strategy. And it would seem to me that your suggestion is that focusing on the urine sodium-based strategy is a little bit more, let's say, effective, scientific, or valid.
Yes, that is correct. The reason being, ultimately, heart failure is a sodium-avid state. When we are talking fluid, we're kind of not very accurately trying to say that, but ultimately the goal of decongestion is achieving a net negative sodium state overall. So you can be excreting, 3 liters of urine in 24 hours and everybody is clapping their hands. But if the net negative sodium state was not achieved, it doesn't matter. It never mattered in the first place. And the second point that I also want to make is, why is it primarily a sodium-avid state? It's because of the neurohormonal perturbations that led to that with the, malaberrant ROS and sympathetic nervous system. And hence, the treatment of heart failure and decongestion simultaneously involves GDMT. If you don't implement GDMT, you can decongest all you want. A few weeks later, your patient will be exactly where you found them now, because you never treated the underlying problem in the first place. So they go hand in hand. Unfortunately, both GDMT and decongestion cause your creatinine to go up. And that is why our fixation with this creatinine up and down has led to the fact that these patients with cardiorenal syndrome leave the hospital with persistent congestion and on suboptimal.
And readmitted, So true.
And then they get readmitted, and then we wonder why they got readmitted. So
exactly.
that is, I think, the drive home point.
And the final concept I want to leave the group with is that for the longest time, there's been this talk of sequential nephron blockade, and I think it was validated by the ADVOR trial. So I think we should employ a strategy of sequential nephron blockade at different parts, such as the thiazides, the loop diuretics, and acetazolamide, as the ADVOR trial showed. And it should become part of our almost guideline-directed CRS management.
I fully agree, for the simple reason that, we have been as a field so hung up with escalating loop diuretics without understanding that beyond a point you're flogging a dead horse. You're using one mechanism, one pathway. Yes, they're effective, but we have other tools. We also forget other tools we have, not only acetazolamide, SGLT2 inhibitors cause natriuresis.
Of course.
Thiazides, are in combination with loop diuretics. It is, it's fairly prevalent in clinical practice to reach out for them. But like the point you make is we could do it sooner. Why wait for the patient to get really congested and then do those things to them? And don't forget MRAs. Aldactone, good old aldactone, which is an old friend, in higher doses is a very powerful natriuretic agent. The nice thing about SGLT2 inhibitor and MRA is not only can they be used for decongestion, they're also two pillars of GDMT. So you're killing two birds with one stone because you're both neurohormonally optimizing and you are decongesting with those agents.
So we have many, many tools in our nephron toolbox.
Yeah.
Thank you so very much. We're going to have you back next year.
Thank
Don't
you.
go
It was
far.
a pleasure being here with you. Take care. Thanks.
Thank you, Janvi.
Bye.
Take care.